Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
Good morning, good afternoon, wherever you are listening to another episode of Health Law Talk. We're back in the studio. I'm Conrad Meyer.
Rory Bellina.
And Rory, I don't know if our listeners have been following the news this week, but I got to tell you, it was wild on Washington yesterday. I think it was January 22nd. What was going on?
Yeah, so yesterday, I think you mentioned, we were talking about this before the show, but 5 of the big health insurance CEOs had to go before Congress. They kind of had these back-to-back staged hearings. So we had UnitedHealth, CVS, Elevance, Cigna, and Ascendiun. So they were all in Washington going through some congressional meetings and hearings from both sides.
It looked like from what we saw, it looked like both parties were grilling the CEOs on various issues. It looks like they were talking about PBMs, which we have not really done a show on, but we really need to.
Sure.
Because I find that topic very interesting. Most people don't even understand what a PBM is. Talking about ACA and the expiration of the subsidies, so the premium increases, and then talking about AI, and everyone seemed to be mad. Like there was absolutely. I think there was one time I saw both parties. Everyone was mad at the CEOs.
Yeah, I think that from, like you mentioned, from both sides, they are getting a lot of pressure from their constituents back home, and then from other people in Washington. Things aren't going great with healthcare on a national level. We've got kind of the roll-off of these subsidies under ACA that we're going to talk about. So I think that's a concern. The PBM and the consolidation of these PBMs with these big health insurance companies and how they are forcing out these smaller independent pharmacies. I know we're going to have a future episode exactly on that topic. It might take a couple episodes to fully cover and explain what's going on, but those are the two things. So we've got these major, I would consider them Fortune 500, Fortune 100 health insurance companies that are basically running the market. And there's real concerns about, there really is a monopoly, but how costs are only going up and it's ultimately affecting the taxpayer.
And we don't want to forget about the AI-driven denials, we're hearing about AI and everything lately.
Sure.
And so now we're hearing about insurers using AI on denials. So we're going to talk about that. We're going to break it all down for everyone today and see how this affects your practice, you individually, and how we're going to get through this. So let's get right to it.
Yeah.
So yesterday, before the House Energy and Commerce and Ways and Means, the 5 CEOs. You got Stephen Hemsley, David Joyner, Stephen's United, David's with CVS, Gail Boudreaux from Elevance, David Cordani with Cigna, and Paul Markovich with Ascendiun. All were on the hot seat. What was very interesting, and I could see it from watching. But I saw AOC yelling at people. I saw Republicans yelling. So it seemed everybody was on the front line battling the CEOs. So
yep.
I never seen that. Finally, we have some bipartisan agreement on something.
Yeah, and the timing's interesting because I know that there's been a lot of criminal hearings on the federal level from the UnitedHealth shooting that occurred back, that was now, I guess, December of 24 when that occurred.
There's a lot of anger for that.
Yeah, and that kind of, it's horrible what happened, but it really, I think, did open up the eyes to a lot of these Washington politicians on health insurance and how detrimental it can be to families, the costs that are incurred on the employer side. If you're listening and you own a business, the costs that you have to incur to insure your employees under ACA, or just to have an employment staff because all of your competitors are doing it as well. So I think that, Congress is obviously concerned about this. And another, big segment is this ACA subsidy expiration that we're going to talk about, that people may or may not even know about what's going on with it.
Yeah, and I think we're going to go into the prior authorization and the AI claim denials, and then which I think really is going to get interesting, and then finally the PBM issue. So let's start with the premiums.
Sure.
So what happened with ACA tax credits or the subsidies, whatever you want to call it. What's the story behind that?
Yeah.
I know they ended in December of last year. So just economically, what does that mean for premiums?
On a very high level basis, essentially what occurred is that those enhanced ACA tax credits expired at the end of 2025. So that's going to cause an increase in premiums for millions of Americans, unfortunately. House Ways and Means Chair Jason Smith out of Missouri, he opened up by saying that his staff put in a report that the average family insurance plan now costs over $27,000 a year. So when you break that down, roughly you're a little over $2,000 a month. If you consider the average family has 4-point-something members, I think is the latest census data. That's where the costs are. So you're talking about a major expense of over $2,000 a month on average for families. And that's just for the coverage. That doesn't even address the deductibles portion, which have continued to increase. So, the other part about this is that the marketplace, it's not just a problem with the ACA marketplace. On the employer-sponsored insurance side, they're also seeing very large premium increases, especially if you would compare to 15 years from now. And I believe there was a stat listed yesterday from the Urban Institute that 7.3 million fewer Americans will have subsidized coverage.
Yeah, but
this year.
that follows through with what happens. So the subsidies expire, it gets more expensive. Like you said, it doesn't just go with ACA policies, right? I mean, you're talking about employer-based policies. And let me ask, when have we ever in a given year seen an insurance company come back on an employer-based in premium and say, "Oh, we're going to have a decrease. We're going to have a decrease this year." Never happens. Never happens.
The Affordable Care Act or Obamacare, depending on how you refer to it, it should be a case study on how you have a plan in mind, or how the government, the federal government, has a plan in mind, how that plan gets implemented, and then how it ultimately fails. Because I think we're starting to see the failure of ACA. I think that if you were to say, if I asked you to summarize what was ACA put in place for, what are you going to tell me?
I'm going to tell you that was largely meant to cover uninsured by using a mandated premium for young people to offset the cost for the covering the uninsured.
Yeah, that's a very good summary of what it was. The goal when President Obama was in office was that there were millions of Americans that were not insured or underinsured, and they wanted to put into place a mandate, and it got challenged all the way up to the Supreme Court. But a mandate that every American needed to have some form of insurance because the Medicare Medicaid system just couldn't sustain it.
That's right.
So they did the best that they could. I think that they had a good goal in mind, but then the insurance companies took a punch on the nose, right? When they were all said, you all have to participate in this. You have to offer this coverage to now millions of Americans that before were probably considered uninsurable, right?
Right.
So,
and remember, once you're in, there's no pre-existing exclusion, so that risk pool,
cancer,
no pre-existing, deny, right?
Right.
You're in the pool.
So you're in. So, and the health insurance companies had to do it. They were mandated to do it.
Yeah.
Now I think the health insurance companies are starting to slowly recoup their losses and get back to.
But wait, hold on a second. I'm gonna call you out on this. Do they really have losses? I mean, did you see some of the profit margins from some of these folks?
That's fair.
So wait, and then I understood that ACA, now we're getting a little bit off here, the medical loss ratio regulations were required to have a 90% or something like that of the premium goes directly to healthcare. Yeah. And then, so that was, I thought, the stopgap to sort of, keep the insurance companies honest and say, if you're not spending 90% of the premium on healthcare related services, that you need to, cut it down. But it still goes up.
I think
it still goes up. I don't get it.
Yeah, that's correct. You're fair to call me out on that. I think loss is the wrong word. There was a loss in their revenue, not a loss to the insurance companies. If they were making $100 million when the ACA ACA came into effect, now they're making $80 million.
But
they want to get back to the 100.
But their delta is still high.
They still have a positive
it's
number.
Way more than $80 million. They're talking billions of dollars here.
Right. I was just using that as a crude example.
I get it.
There's still a positive number. They want that number to be more positive. So I think that's where we are. So What was interesting, I know you want to talk about, what was your thought on some of the responses yesterday?
Man, I watched Stephen Hemsley from United testify that insurers, are completely compete aggressively to keep premiums affordable. I can promise you the American people will look at that and say, really? Are you kidding? Do you do that? And then I think he shifted the blame to say, well, and I have my notes here saying that really the premiums are determined largely by a broader healthcare system. What does that mean?
Yeah, well,
what in the world does that mean?
I think he and the other CEOs all kind of backed each other up and said, we need to look at hospital costs. We're not the bad guys. It's these hospitals. We need to look at prescription drug prices, which is a slippery slope because a lot of these insurance companies own PBMs, and what they called healthcare inflation. I don't think the members of Congress are buying that, though.
Not only do they not buy it, but I think, if, again, to your point, are we going to be honest here? Because now you've got insurance companies owning PBMs. They set the rates. They set the prices, right? Now you have insurance companies also on the front lines owning primary care clinics. So
and demanding or requiring that you have to use a brand name drug versus generic.
Correct. So I find it to be a little bit disingenuous to go in front of a committee and say, oh, we're doing this. We're doing the hard work here. We're doing it hard. Yeah. We're being so tough. And yet what they don't tell you is, well, we also own the PBMs. Oh, we also own the clinics. We also are the gatekeepers of the care. Mm-hmm. So, yeah, we're all that, but we're not going to tell you that.
Right.
So
what did they say about prior auth? What did I remember that came up from my notes from the members from both sides were talking about prior auth.
This statistic is really says it all. So you've got 1 in 5 medical claims are denied. 20%.
I thought it'd be higher than that. Honestly.
I was a little higher than that, but still. Yeah. Here's the kicker. Ready for this? 82% of Medicare Advantage denials are overturned on appeal. 82%. So what is that? I mean, that tells you that there's something wrong with the system. I mean,
it's an automatic denial.
Correct.
Most likely at the
correct.
gate.
So let's just do a frontline automatic denial. Hopefully no one will appeal. We'll save some money that way. Sure. And you know what? The people don't get the care they need. That to me is unconscionable. That's unconscionable. I'm sorry.
One of the members brought up yesterday some AMA survey data that 61% of physicians believe insurers' use of AI is increasing prior auth. So
I guarantee you that.
I guarantee that. Yeah, I think that's absolutely occurring because there's no way that anyone is looking at these.
Can someone answer this question for me? And I've asked this question a lot, Rory and myself, in my practice over the years. How is it that the use of authorization or denials, how is that not the practice of medicine?
We're going to get to that. I actually have a note that I want to talk about that.
Oh, you do? Okay.
Yeah. I want to talk about that.
That's just nuts to me.
Yeah. All right. So I had in my notes that I wanted to ask you, what were your thoughts on the PBM issues? I know AOC brought this up, and she got very upset about it in regards to the consolidation of PBMs with these healthcare insurers.
Well, it's kind of like what you're seeing in other businesses. I mean, you've got these massive companies buying up and controlling PBMs, and even payers that are controlling PBMs. And what people don't understand are PBMs were supposed to be like they're
supposed to advocate
for the individual, right? And instead, what they're using there is almost I call them like the hidden mafia, the prescription mafia,
the middleman, as they like to be known,
and they're controlling all of the rates, all of the prices. So, to me, when I read earlier, was it last week? I read that our HHS secretary, he mentioned about Kennedy, right? Is it Robert?
Robert. Yeah, RFK.
Yes. RFK. He mentioned that now we have a most favored nation's pricing for Medicare for prescription drugs, which I thought was interesting. So I can see the fight. You've got these companies now controlling the middlemen. They're controlling the access. They're controlling everything. So I find it very disingenuous. You see Hemsley in front of a committee saying, we're trying to be aggressive, but yet, and I don't think the committee members understand the breadth of this and how depth and the inner workings of this, because there's a lot of control, especially at the PBM level. Yeah.
What I thought was interesting was a comment that I believe that it was brought up. I think AOC, I was actually quoted saying it yesterday on the record that her analysis is that CVS Caremark manages 30% of all prescriptions.
That's nuts.
So you've got one health insurance,
30%.
CVS Caremark, yes. and managing one. So you've got one PBM that has the largest chain of pharmacies.
How is that not antitrust? I don't get that.
Managing that.
I'm surprised FTC. Now I'm not an antitrust lawyer, but I could.
Because a lot of people, I'm sure our listeners know this, but CVS also owns health insurance companies.
That's right.
So you've got this complete vertical integration. You've got United with Optum, and
you're telling
PBM.
me there's no Chinese walls in there, that there's sort of conflict of interest. I mean, you're telling me they don't build. I guarantee you they're sharing information with each other. Guarantee you.
And the goal is to keep you within their own system, so the money stays there. And ultimately, it's hurting, I think, the patients and these independent pharmacies.
No competition.
Yeah, there's
no
none.
competition.
And the CEO's response is that, well, by doing this, by Cigna owning Express Scripts, CVS owning Aetna Caremark, and then obviously United owns Optum, that creates efficiencies. I don't know if I think that's a very politically correct answer that the CEOs are going to say.
They're on the hot seat.
But what happens when your health insurance company is now telling your PBM, who now employs your physician, or at a clinic that is owned by the health insurance company, you need the brand. You can't have the generic. So you have to pay a higher deductible. Your insurance is going to get billed more. Your premiums are going to go up. But ultimately, we get more. And on the PBM side, which we're going to go into because it's a popular topic, is the discounts and the reimbursements on the PBM side.
That's right.
The savings never go to the patient. The savings go up.
They pocket the delta.
Absolutely.
So now the PBM becomes a moneymaker.
Yeah. Oh, absolutely.
Absolutely. So
why would these insurance companies want to get into pharmacy?
Because they can control it.
They know that there's so much money on the pharmacy side, especially as we're getting a aging United States population.
Well, and one thing I want to tell you, and that goes back to what I was saying, the vertical integration of these companies, whether it's these payer companies into the care market, meaning the PBM and then the primary care, right? I find it creates a complete conflict of interest, total conflict of interest. And so I'm very interested to see what the future holds for that in terms of legislation. Is it we're going to legislate this at the federal level? Do we even understand the depth of how far it goes?
Right.
I don't know.
I don't know either.
I don't know.
All right, so let's jump back to what happened with these subsidies.
Got it.
So again, they expired. The enhanced subsidies, I'll say, expired 12/31/2025.
Recapping that, right? So they're gone. They're gone now. So now premiums are skyrocketing. What's the average?
Average family employer plan, $27,000 per year was cited yesterday. Out of pocket maximum on average $20,000 per year.
That's staggering.
Yeah. Prior auth, like we said, to summarize, 1 in 5 claims are being denied. 82% are being overturned on appeal. So it's an issue. Congress is aware of it. What are they going to do with it? I don't know, if anything, because I think the insurance companies, like we said, they want to get that delta back to be even a bigger delta for them. And here's how they're doing it. They're scooping up these pharmacies and buying these PBMs.
So one of the things when you talk about claim denials, and I think it was very interesting yesterday, and you're looking at the data that we just talked about too, is AI in healthcare.
Yeah.
And I wanted to bring up which brings up to our next part that we're going to go talk to our listeners, is the new Medicare AI pilot
Wiser.
program.
That's right. What a great name. I love acronyms.
Who comes up with that? That's pretty good.
Congressional staffers have to, because there's always a great acronym for a new program. So the Wiser program, what is that?
Now, I think this is very important because I don't think enough providers even have this on their radar right now about what's happening. So CMS launched what they call the Wiser program. Let me spell it out for you. It means wasteful and inappropriate service reduction. Now, it starts literally just a few weeks ago.
Yeah.
January 1st, 2026. It's going to run for 6 years in 6 states. Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington.
Okay.
Now, here's the great thing. Louisiana isn't part of it yet, but providers need to pay attention because this could expand nationally. And if you're a provider in Louisiana that does work in Texas, okay, right next door, you might need to be aware of what's going on.
Interesting. I'm curious how they pick these states, but
maybe out of a jar.
We've got some big, maybe out of a jar. Yeah, I mean, I don't. There's really we've got some big states, we've got some small states, some blue states, some red states.
But the interesting thing, the companies that are doing these AI reviews get paid on the savings.
Yeah.
So, I mean, CMS is really big on reimbursing for savings, right?
Right.
Because they're trying to keep costs down. So, But think about that for the incentive, like the savings. What does that mean? So are we going to deny more care and just reap the savings?
I think, to summarize what Wiser is, it's Medicare's goal to apply AI and machine learning to prior auth decisions for traditional Medicare, so not Advantage, but your traditional beneficiaries. They're saying that there's safeguards in place. CMS is saying that a qualified human clinician, I don't know what a human clinician is. Is that...
Yeah, well, what does that mean? Is that like an LPN? Or I mean, what is that?
Who is considered a clinician?
Are they like a doctor? Do we know?
That's a great... I'm going to make a note to get more information on that. Must review any denial before it's final. And the vendors can't have compensation arrangements directly tied to denial rates.
Okay, let me stop you right there. Okay, because you know what I found interesting is these denials, and it's unbelievable. And I know you've seen this in your practice.
Oh yeah,
the insurance.
I know what you're going to say before you say it.
The insurance company is putting these doctors. Now, sometimes they're doctors, right? They're supposed to be peer to peer.
They're going to sit in a room like us with a stack of paper to the ceiling or a computer.
But here's my question. If I'm an orthopedic, right, and I'm going to go, I need to do XYZ for a patient. Let's say it's a back surgery.
Sure.
Say I do an orthopedic back and spine, and I go and I get a denial, and then I'm going peer to peer with, like, say, a payer with their doctor.
Right.
And you ask that doctor, well, doctor, what specialty are you? Oh, I'm a
family medicine.
I'm a pathologist.
Right. Right.
So wait, you've never done surgery in your life, and you're making a call about a denial for a back spine issue? Well, yeah. I mean, wouldn't you be outraged?
Yeah,
I mean,
absolutely.
So peer to peer. So it almost, if you're going to have those denials, I think they need to be true peer to peer.
Absolutely.
Peer to peer, because it's much more difficult to look at another orthopedic surgeon in the face and say, yeah, we're going to deny that.
And you've also hired a employee. I mean, they're an employee. You've hired an employee physician to review denials. It's not going to look good if you overturn all the denials that your employee, like your boss, essentially is trying to say these shouldn't be paid. Like you need to kind of they're going to be expected to toe the company line. And so when they get all of these denials, I think they're going to continue to say it's still denied.
So don't have compensation tied to savings. Don't have comp tied to denials, right?
Correct. It shouldn't be.
Shouldn't be.
But your job is to review the denials, and I always am curious about what's the moral boundaries of that physician who's reviewing the denials. Is he truly,
or is it really a physician? I mean, do you see that the Senate 2024 committee report found that AI tools have been linked right to denial claims at a rate 16 times higher than decisions without AI?
Yeah.
And so I want to know is who is programming or prompting or for the AI,
Well,
right?
States are starting to get involved in that. So I know Texas, they have a great acronym for this one, Triaga?
Not to be confused with Traeger.
Right, not the grill. It was a Responsible AI, Texas Responsible AI Governance Act. So I'll call it TREGA. That went into effect a few weeks ago. California has an act. I don't know if it's been signed yet by the governor. But those are regulations that require the disclosure when AI is used in diagnostic or treatment decisions. So states are realizing that this is an issue, and they're doing what they can. Under TREGA as well, if you're a Texas practitioner, you must provide patients with, quote, conspicuous written disclosure of AI use before or at the time of interaction in emergencies as soon as reasonably practical.
What about California?
California prohibits, this is AB 489, if anyone wants to look it up, that prohibits AI systems from using terms or phrases that imply care is being provided by a licensed human professional when it's not. I think that's more of a licensure standpoint as far as is this practicing medicine or not. I think that's the goal behind California. So states are aware that AI is heavily involved in this. Everyone is using it. It makes sense that the government and CMS is going to use it because they get so many claims on a daily basis. And the another topic while we're talking about future topics is I think you and I will summarize this the same, but the CMS Medicare system, it's an honesty. It's an honesty-based system.
Absolutely, it is.
You provide a service, you submit the bill,
we pay it,
and it gets paid. and then maybe we'll audit it, maybe we'll look at it, but it's very much like an honesty-based system.
That's right.
I think, of course, CMS is starting to is going to use AI. Why wouldn't they? To see, are there bad providers out there that are taking advantage?
I think the problem is though, who's prompting that, right? Because AI in itself doesn't it's not self-aware, at least not yet, right?
Right.
But who's prompting it, and how is that being prompted, and who's reviewing the prompt, and who's teaching it to review the claim, and how? Like, what's the process? An agent or whatever they're using to review the claim and deny it. How does that process look? Because I can tell you, I'm skeptical now.
Yeah.
Now look, right now Louisiana has none of this. None of this. Like I said before, if you're practicing in Texas, if you're going across state lines, if you're a Louisiana doc and you're doing telemed, or you're in both states and back and forth, you need to be aware of this.
Make sure. So, like you mentioned, Louisiana, the concern for Louisiana, if we're going to focus here on a couple of things briefly before we wind down, is that this ACA subsidy, it's definitely affecting Louisiana hard. There's estimates that over 200,000 residents were enrolled in the ACA marketplace plan, so they're going to see those premiums, unfortunately, double, triple.
Now, look, here's the problem.
What happens if you can't afford that?
That's another problem. So in typical, right? We have our charity care. Sure. Everyone will go back to the ER just like it was before. Then you got Dispro. Right. So you have dish payments, right? So you're back to uncompensated care, where the hospitals are going to have to seek reimbursement for that through some sort of a subsidy or a dish payment, right?
So now you're going
back to the old system,
back to the old model of ER
visits,
5-hour waits.
That's right.
Horrible, not always, but unfortunately, a lot of horrible outcomes.
That's
or
right.
Outcomes that could have been prevented because it's underinsured.
Despite the fact that we have an urgent care at every corner, it's almost like a Wendy's, right?
Right.
Or like a whatever fast food. Yeah. You look at, there's an urgent care. There's another one, like a Starbucks. Like urgent care everywhere.
Yeah. In our neighborhood, there are more urgent cares, I would say, than any other business. If you had to look at it, it's incredible. What about, so are you aware of anything on the Louisiana level for transparency requirements for AI here yet? Yeah, I don't think that there's anything.
And you know what? I hate to say it, as much as I love our medical board, I think
they're going to have to
They're going to have to jump in and get involved. I can promise you right now.
They're talking about it.
They're talking about it. And I also think that it's very interesting. I remember when Epic came out, a lot of docs were using Epic templates to kind of get their records done right. And we always counsel them, be very careful about doing that because it could bite you later.
Sure.
And so now I have yet, and I need to get more on top of this. I want to see how has Epic used AI.
Sure.
To integrate, have they used AI? And I'm sure they have. They got to. So, and I need to do some research on that, because I love to know what they're doing from an AI standpoint. So here's another problem. What are we going to do about telling patients about this? I mean, do patients need to know, right, that the doctor they're seeing is using some form of AI tool?
I think that as of right now, and I've experienced this from personal experiences, that I know one big health system here in Louisiana uses an AI transcribing service, and the patients are made aware of it when the doctor walks in the room, that there's an AI dictation transcribing software that takes the encounter, uses AI and machine learning, and puts it in the note in Epic in a draft format, and then the doctor's supposed to obviously go through it, make changes, and so forth. So I think that that's an efficiency thing, that it's patients were probably recording their interactions regardless, so now the doctor is doing it. I think that's for an efficiency thing to get things done a little bit quicker. I also think it could enhance reimbursements, because a lot of times when a doctor, after their encounter, they have to go in the note, they have to put in there their charges, and the scribe looks at it, or the biller and coder looks at it and decides what to bill and code. Well, if this AI is now programmed to listen to this and to pick up key words, I think these bills are going to get bigger and bigger. I think it's.
Oh, I guarantee they're going to get bigger. But then the question
is, it's listening for words that are CPT codes, essentially.
Okay, so let me throw this at you. So tell me this shouldn't be on DOJ's radar, right, or OIG's radar. So upcoding. You're telling me that AI and using AI to prompt, like, in other words, if I'm a UR person, right? And I'm going through on a record and trying to figure out how do we maximize reimbursement on an E&M code from a level 1 to a level 5, right?
Yep.
And I'm looking, okay, so I'm gonna say tell Jarvis, you're gonna need to look at this, and this, and then when you assess the node, you can decide if it's properly coded as a level 3, a level 4, a level 5. I promise you.
Or you're going to give it someone is going to develop a large language model learning system where it could very much say, look at this patient record, listen to this patient.
We should do that. We should make it up, right?
Let's go off air so no one here steals our idea.
Yeah, steals our idea.
Let's, but no, in all seriousness, I'm sure that there's LLMs that are designed to listen to a full record with the prompt in mind of upcode this as much as you can. Because we're going to listen to everything. And if the doctor mentions this, let's run that lab. Let's run that panel.
I can promise you this. OIG is not going to give 2 cents about AI doing it. They're going to say, you know what? If it wasn't actually done or this note was modified, you're on the hook.
Yeah.
And I don't care if Jarvis did it. So I'm sorry to all the Jarvis fans because I do like Jarvis. But, I think honestly, it's going you know what else is going to be interesting? Using AI from a UR standpoint for peer review. That's good. So imagine your quality assurance committees, your quacks, and see, and if you got a peer review issue, are they going to be using AI, right, to assess competency? That's true. Or or if you're going to have a AI driven on for M&M conferences on your mortality morbidity rate.
That's a good point.
So I could see AI coming in all aspects of healthcare that have not been infiltrated yet. Right?
Yeah.
Interesting. So in the end, where are we, Rory, on the takeaways here? So I think we covered a lot here for the listeners. And so what should we take away?
I think that the key is that doctors and providers, they're going to face this uphill battle with fighting prior auth and prior auth denials. The key there is going to be the documentation in your record and really staying diligent for that. Unfortunately, that I think that's a big theme of what we see going on and having to fight these with AI, because you have to presume now that there's AI on the other side of every bill or prior auth request that's reviewing it and trying to find a way to deny it. Unfortunately, fortunately, I should say, statistically, most denials are overturned on appeal. It's burdensome. It takes a lot of staff time. But if you don't appeal, your practice is leaving money on the table, and you've got patient harm issues as well.
Yeah, and look, I guess when we're talking about appeals, just like we saw on the Medicare Advantage, the 82% are overturned. Yeah. So I think, and here's another thing: when you talk to physicians about this, they can't stand the red tape and the paperwork. Sure. But you have no choice.
Yeah.
You have no choice. Someone's got to be working those claims, and usually they have medical billing providers. But again, that takes money off the table. So I can see leaving. If you don't appeal and you don't fight this, you're leaving money on the table.
Yeah.
So
I think that's a good summary of everything, and we just have to wait and see what's going on. The one big beautiful bill that Congress is still kind of working through. I expect there's going to be healthcare updates in there as well.
Yep. And I think for hospital administrators, medical staff, look at AI policies and see how AI is integrated in your facility, and also for physician practice, how are your practices using AI, and how are you documenting the quality checks for that? So I think that's the main thing. And lastly, I think to wrap it up, watch for the legislation and watch for the regulation. Yep. I can't imagine the State Board of Medical Examiners here in Louisiana is not going to put their hands on this. And I now whether the legislature does, that's a whole different story, because I don't know how in the weeds they are, but I guarantee you, I think the State Board of Medical has to. And not just them, but all providers. So the Board of Psychology, anyone who is, Board of, counselors, anyone who does direct patient care on a board level in this state needs to be looking at this, I think. So I think right now we got a lot of material coming on. This is going to be a really, really good year. Yeah. And I want to thank everyone today for listening. Rory, any final comments before we wrap it up?
No, just stay tuned. We'll continue to update it. I like this topic. I like it on the national level, so stay tuned. Yeah, we'll stay tuned for some more AI topics, PBM topics. And again, drop us a line if you have anything to say. Reach out to us. Rory and Conrad, always listening to you guys. Leave us that 5-star rating. Thank you for listening. Have a great day, and look forward to our next episode. See you.
Thanks for listening to this episode of Health Law Talk, presented by Shahardy Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardy Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardy Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.